Hi there, I'm Catherine O'Brien. I'm the lead cancer nurse here in St James's Hospital in Dublin. This is the second video in a series looking at some of the finalists from 2013 Quality and Care Oncology Awards. In this video I'll be telling you about a project we carried out here in St James's to evaluate the effectiveness of a nurse-led risk assessment tool to reduce the incidence of febrile neutropenia, or FN as we locally call it, in adult cancer patients receiving myelosuppressive chemotherapy. Febrile neutropenia is a life-threatening consequence of chemotherapy that affects about 6 to 22% of all cancer patients, depending on their tumour type. For patients, it means severe illness, emergency visits into the hospital for intravenous antibiotics, time in hospital, increased anxiety, additional time off work, and a wider disruption to their family life. Plus, of course, the potential for dose reductions and treatment delays that can have a significant reduction in the effectiveness of their treatment and impact on their overall survival. So, as well as having a huge impact on the patient, the FN also has a huge impact on the clinic here, on the nursing team and other patients. We have only 12 couches here to enable us to give chemotherapy and treatment to our patients, and we have on average about 100 patients a day coming for their treatment. So if somebody comes into our clinic with FN, they have to take up one of these couches for the majority of the day until we have a bed up on one of the wards to transfer them to, which is usually in the afternoon or in the evening time. So a lot of time this does interfere with the clinic times, patient treatments, and there's long delays for other patients. We were seeing this happen more frequently, and this led us to look at how we could identify patients who are at risk of developing FN. We know that growth colony stimulating factor, or GCSF, can be given to patients at risk of FN prophylactically, or a secondary treatment if they have already developed an FN in the past. International evidence-based guidelines are available that state that formal assessment of patients' FN risk should be conducted based on their chemotherapy regimen as well as other risk factors to determine whether they should get GCSF or not. Despite these guidelines being in place for over 15 years, there seems to be no formal assessment process either in Ireland or in the UK. A number of studies in America have demonstrated the benefit of formal risk assessment, and we wanted to evaluate this approach here in Ireland. We carried out a nurse-led clinical study to design, implement and determine the effectiveness of a risk assessment tool to reduce the incidence of FN. We developed a single-page FN risk assessment tool which was based on the European and international guidelines. There was 25 patient treatment and disease-related FN risk factors. This also included social risk factors such as distance that they lived from the hospital and whether they lived at home, because we felt that these factors could also impact on their prompt presentation to us here in the hospital if FN did occur. 459 patients were included in this study over 2 phases. For the first phase, standard procedure was used to determine FN risk. During the second phase, all patients with solid tumours or lymphoma with a new diagnosis or a change in the regimen were assessed by a physician or a nurse using the tool to determine their risk of FN and their potential need for prophylactic GCSF. When we analysed the data, the results really spoke for themselves. There was a 52% reduction in FN during the second phase of the study. The days in hospital for FN were also reduced by more than half. Antibiotic usage and the length the patients were staying in hospital with an FN also reduced significantly. Patients' treatment delays reduced by 38% and the dose reductions reduced by 21%. And as we said before, this is hugely important for the outcome of the patients and their overall survival. Despite these significant reductions in FN, GCSF usage only increased by 12.5%, which we found extremely interesting. This demonstrated that the tool actually optimised the GCSF use and made prescribing more accurate and more appropriate. Since the study ended, we've implemented the risk assessment tool into the unit as standard procedure. Overall, clinical outcomes and the quality of life for these patients has improved. The reduction in emergency visits due to FN has been felt widely across the clinic. Treatment appointments for all our patients are a lot more streamlined, and there's a reduction in the waiting times for the beds in the unit. There's also been a wider economic benefit to the hospital as a whole through the reduction in hospitalisation and the reduced antibiotic usage. Plus, our teams are more educated when it comes to FN, as well as the impact on dose reductions and treatment delays for the chemotherapy patients. Since we conducted our study, the initiative has been rolled out to 4 other units across Ireland so far. We've also spoken at a number of conferences and run workshops both within Ireland and in the UK. We really hope that this long overdue standard approach to FN risk assessment will be used in many more oncology units in the future. If you're thinking of implementing something in your own unit, please get in touch and we'd be delighted to talk to you about our experiences.